All right, ER nurses. Let's paint a picture we probably all know way too well.
Go on.
You're maybe 10 hours deep into your shift, and that patient in room 7, still very much your patient.
Yep. The inpatient hold.
Yeah.
Feels like they've been there forever sometimes.
Exactly, maybe days. They came in really sick, got the whole workup, and, somewhere in that whirlwind, a Foley got placed.
Standard procedure in many acute situations.
Right. But now, that tube, which seemed so helpful, maybe absolutely essential just hours ago, well, it's just lingering.
And in the ER chaos, it's not just sitting there harmlessly.
No, it's quietly becoming this ticking liability.
A potential problem waiting to happen.
We all follow strict cleaning protocols, right? We clean, we care, we try to educate.
Of course, perineal care is fundamental.
But in the ER, let's be real. You're juggling multiple complex patients. Maybe 2 are waiting for an ICU bed.
It's relentless. Relying just on routine hygiene to stop an infection from an indwelling device. It can feel like, I don't know, bailing out a sinking ship with a teacup. That's a good analogy. It often feels insufficient for the scale of the risk.
So today, we're not just bailing. We're trying to pull the plug on the problem before it starts.
Okay.
We're doing a deep dive into a proactive strategy. Foley catheter stewardship.
Playing offense, not just defense.
Exactly. It's not about cleaning up the mess afterwards. It's about preventing those CI catheter-associated urinary tract infections before they even get a chance to leave your department.
A preemptive strike. I like it.
Think of it as a shortcut, almost, to stopping a major hospital-acquired infection in its tracks.
And that's really why this shift, this change in thinking is so critical, especially for ER nurses.
Right. You're right there at the front line.
Absolutely. You're dealing with a constant turnover, managing these long holds. So this takes what often feels like just defending against CRT's eyes.
Yeah, like constantly cleaning.
And turns it into a truly offensive strategy. And what's really important here, and frankly pretty urgent, is that CRTI risk isn't like static.
It's not 0, 1 minute and high the next.
No, it climbs. Every single hour that catheter stays in place, the risk goes up.
Wow, every hour.
Every hour. So understanding how to be proactive, how to kind of intercept that rising risk while that patient is still under your direct care in the ER. That's absolutely key.
Leveraging your position right then and there.
Precisely. It's about making an immediate impact.
Okay, so if standard perineal care, even when done perfectly, isn't quite enough in the ER, what's the sort of fundamental problem once that catheter is actually in place?
Yeah, you've really hit the core issue. The ER is just, well, it's fast-paced. It can be a pretty dirty place, let's be honest.
Lots of traffic, lots of germs.
Exactly. And it's just not designed for the kind of continuous, super meticulous, long-term care you'd need to completely eliminate the risk from that indwelling device.
Right.
Once that catheter breaks the sterile barrier, you've basically created a direct highway for bacteria.
A highway. Yeah, that makes sense.
And no amount of cleaning, no matter how good you are, can fully erase that fundamental vulnerability.
Right.
So that leads to the really important question. If just cleaning isn't enough to get rid of the basic risk, shouldn't we be focusing more on the device itself?
On the catheter being there in the first place.
Yes. The presence of the device is the biggest risk factor.
Right. And it's really important to stress this isn't about pointing fingers about why it was put in initially.
Absolutely not. Often it's completely necessary at the start.
But it's recognizing that a catheter should never just be for convenience. Not for the patient, and let's be honest, not for us nurses trying to manage a crazy workload either.
Convenience is never a valid indication.
So stewardship really means stopping that infection from even getting a chance, which means we have to critically look at whether the device is needed at all, being truly proactive.
And that brings us right to the core idea, playing offense.
Okay.
To really get what stewardship means here, maybe think about antibiotic stewardship.
Okay, I see the parallel.
Yeah. Remember years ago, before it really took hold, we saw this scary rise in novel superbugs.
MRSA, VRE.
Right. We were giving out antibiotics pretty broadly, maybe sometimes without super clear reasons, and it led to resistance, worse outcomes.
Yeah, we had to rethink that.
We had to question why we were using them so much. Catheter stewardship is the exact same logic.
Yeah.
It's questioning the Foley itself.
Especially for those patients just boarding, waiting for a bed upstairs.
Exactly. This invasive thing we do, it's meant for a specific reason, but it can cause real harm if it stays in longer than needed, or if maybe it wasn't truly indicated to begin with.
It's challenging the default assumption.
Precisely.
So in the middle of our ER chaos, boarding patients, hallway beds, new patients rolling in constantly. What does catheter stewardship actually look like on the ground? Are we supposed to scrutinize every single Foley?
Yes, you are, but again, it's not about blaming whoever put it in.
Okay.
There are totally valid, often critical reasons, right? Like strict I&O for a shocky patient or known chronic retention, or maybe urology specifically signed off on it.
Sure, those make sense.
The key is, once those initial acute reasons are resolved or just aren't relevant anymore, that's when we need to pivot. We need to challenge the common, maybe less critical practices.
Like what? Give me an example.
Okay, perfect example. Do we really need a Foley just for temperature management in an intubated patient?
I've seen that done.
Me too. But there are actually great alternatives now, like an endotracheal temp probe, especially for longer-term monitoring.
Right, less invasive.
So it forces you to ask, is the original reason for putting this Foley in still valid right now?
Yeah.
Or could we use something else?
That really shifts things, doesn't it? Because the most powerful part of stewardship then becomes recognizing when a patient can actually manage without the device.
Bingo.
Even if putting it in was totally the right call initially, that acute need might be gone by the time they're just waiting in our department for hours or days.
And this is where you, the ER nurse, become absolutely crucial. You're the gatekeeper. You're the key master in this whole process.
While they're still under our care.
Yes. While that patient is still your responsibility, in your unit, you have the power, and I'd argue the obligation, to question if that catheter still needs to be there.
So if the acute reason is gone,
Then it's time to think alternatives for just managing continence. We still need to keep patients clean and maintain dignity, of course.
of course.
But there's no reason someone who can use suction can't use a wicking device, right? The dude or dudette wick, as some call them.
Yeah. Those can actually work pretty well.
They can. These seemingly small changes, these alternatives, can make a huge difference in stopping a future CRUTI and improving comfort, too. It's about being proactive and, honestly, a bit creative sometimes.
Okay, let's make this really actionable, especially thinking about those long ER holds. You said there were two parts.
Right.
The second big piece of stewardship is actively speaking up to get a catheter removed if it's not needed anymore. Or maybe looking with fresh eyes, it wasn't really the best choice to begin with. And like you said, that COUTI risk goes up every single hour. Your ER hold patient has probably racked up quite a few hours already, with more likely on the way.
They have. So what do? You absolutely cannot just pass this problem along to the next shift or just hand it off to the floor nurse upstairs.
That's just kicking the can down the road.
It is. And this is maybe the most crucial point. Getting that catheter out while the patient is still your patient is the single biggest win. Full stop.
Why is that timing so critical?
Because you know it's going to be a while, sometimes a really long while, before the nurse upstairs who's getting multiple admissions can even think about addressing it.
True, there's swamps too.
So here's your concrete action. Before you even call report to the floor, use your secure chat. Send a quick message to the admitting doc or the team.
Like what?
Something simple. Hey, patient in room 7, the frequent flyer. Stable now, awake, can use a urinal. Don't think the Foley is needed anymore. Okay, if we pull it before they go up?
Quick, direct, proactive.
Yes. Taking that step while they're still physically in your bay. Immensely powerful. It's about seizing that moment you have control.
That's a really strong way to frame it. So for your holds, the job isn't just keeping them stable until transport arrives.
Not at all.
When you take over care for an inpatient hold, assessing that Foley needs to be part of your initial assessment every time. Question why it's there.
Is it still valid?
Right. Think about that CHF patient. Came in crashing, needed Lasix drip, strict I&Os. Foley was absolutely the right call then.
Textbook indication.
But now it's day 3 in the ER. They've been off the drip for a whole shift.
That's your cue.
That is the moment. Pull the catheter. That is
Yeah.
active stewardship in practice.
Exactly. And removing it doesn't just lower their CAUTI risk right then.
What else?
It actually helps get them closer to discharge from the whole hospital system, not just from the ER.
Connecting it to the bigger picture.
Yeah, it has this ripple effect on patient outcomes, on flow, on overall hospital efficiency. It's thinking a few steps ahead.
And this really challenges the old ways, doesn't it? Don't just assume someone needs a Foley because they got admitted.
Right. That's challenging the status quo. Standard practice should evolve as we get new evidence, new information.
Just doing something because that's how we've always done it.
Is never a good reason in medicine. And ER nurses are uniquely positioned to drive this change right at the point of entry or during that extended hold.
So let me ask you this. What's our most potent weapon against CIUTs that start in the ER?
It's not the cleaning supplies, though they're essential. It's your critical thinking.
Our brains.
Your brains. It's the difference between cleaning up a mess after it happens versus stopping the mess from ever occurring.
Prevention versus reaction.
Exactly. That proactive thinking by ER nurses is the real weapon against these hospital-acquired infections, these nosocomial infections.
And the impact goes beyond just that one patient's UTI risk.
Oh, absolutely. Nosocomial infections, as you know, notoriously increase length of stay. They jam up beds, slow down movement through the ER.
Which affects everyone waiting.
It affects the flow of your whole department, the whole hospital system.
Yeah.
Your actions on that one catheter directly impact bed availability and patient progression downstream.
Okay, wow. Let's quickly recap this deep dive then. Catheter stewardship in the ER.
Let's do
The
it.
basic idea, routine cleaning, hygiene, it's vital. But in the ER environment, with our resources, the pace, it's often just not enough by itself.
Right. The inherent risk of that indwelling device means even perfect hygiene leaves a potential pathway open for bugs.
So catheter stewardship is way more effective because
it targets the single biggest risk factor head-on, the catheter itself.
be rid of the highway.
Exactly. It shifts the whole game from defense and reaction to offense and pro-action. You're stopping the problem before it even starts.
And for you, the ER nurse listening, especially with those borders, your role is kind of twofold, right? First, if you're thinking about placing one, ask, do we really need this right now?
Critical first question.
And second, if one's already there, maybe from a previous shift or EMS, do we actually still need this catheter right now?
That second question is just as crucial, maybe even more so for holds. 2 moments for critical thinking.
Two key moments.
Absolutely. And by taking control of that device, questioning it, advocating for removal while they are still in your department, you're protecting not just that patient, but really the whole hospital from an infection that maybe never, ever had to happen.
We're setting the tone for their whole stay.
You really are. You become this critical checkpoint in the hospital's infection prevention strategy.
So the final thought for everyone listening, you are the first and arguably the most important steward in this whole process. So think about this. Amidst all the craziness, the demands of the ER, how can challenging this one single medical device, this seemingly small action, how can that become one of the most powerful things you do for patient safety?
Yeah.
Not just in the ER, but for the whole hospital.
It's a powerful question. Because your critical thinking, your proactive step right there in the ER, it makes you more than just a frontline caregiver.
Yeah.
It makes you a vital leader in the much bigger fight against all hospital-acquired infections. That initial decision or that timely removal, it sends ripples throughout that patient's entire hospital journey, affecting their health, their stay, and the flow of the entire system. You have more impact than you might realize.